Good afternoon, and thanks for the opportunity to speak to you today. So I'll talk to you a little bit about relapsed Waldenström's and the options we have as far as treatment. But I think the first thing and the good news about a lot of relapsed Waldenström's is that it doesn't necessarily need treatment at the time the relapse is found. So just as Dr. Anderson has shared with you some of the indications for frontline therapy, a lot of those reasons are the same reasons that we're looking to treat at the time of relapse, meaning are you having symptoms such as fevers, drenching night sweats, weight loss? Are you having progressive neuropathy or increasing fatigue? On physical exam, we're looking for signs of significantly enlarged lymph nodes, bulky liver, bulky spleen, progressive neuropathy on exam. When we're concerned about the blood becoming too thick, we often do eye exams, looking at the vessels in the back of the eye and the retinal vessels, and we're looking for, they're called sausage vessels. They look like sausage links when the vessels get engorged because the protein levels have risen to the point that the blood is getting too thick. The other things we're looking for are on our blood tests, meaning are we seeing progressive falls of hemoglobin, progressive falls of the platelets? On CT scan imaging, are we seeing the bulky lymph nodes there or the bulky liver or bulky spleen there? We can, as you heard from Dr. Mikhail this morning, we can measure the serum viscosity by blood test and see if that's quite elevated. And the other things that we're looking at are, is there now evidence of amyloidosis that perhaps wasn't present earlier? Is there now evidence of kidney impairment or evidence of a cryoglobulinemia? Cryoglobulinemia can manifest as ulcerations, usually on the cooler parts of the body, especially the lower legs. And we're looking for evidence that the Waldenström's is maybe transforming to a more aggressive lymphoma. So once we've made the decision to treat, what options do we have? So I'd say at every decision point, or every time a decision is made that treatment is necessary, you should look at both what options are available to you, both on and off of a clinical trial. Because by participating in clinical trials, it expands your option list. The therapies that are available to you are the combinations that are available to you. But sometimes being on a clinical trial is not feasible or not possible, so let's look at what options we have outside of a clinical trial. The first class of drugs we'll look at are the monoclonal antibodies, namely rituximab, its cousin ofatumumab, and another antibody called alemtuzumab that I'll tell you about a little bit later. In combination with these, rituximab or ofatumumab as a backbone, we can add other drugs, including the conventional chemotherapy drugs known as alkylating agents, which are cyclophosphamide and bendamustine. We can also add the nucleoside analogs, fludarabine and cladribine. We can consider stem cell transplant, and I'll tell you a little bit about the data in relapsed Waldenström's with both autologous stem cell transplants and allogeneic stem cell transplants. And if you're not familiar with stem cell transplant, I'll tell you a little bit about what each of these transplants are and how they're done. We'll also talk about the proteasome inhibitors, bortezomib and its cousin carfilzomib. There's also actually an ongoing study with an oral proteasome inhibitor called oprozomib. We'll talk a little bit about the immunomodulators, namely thalidomide, lenalidomide, and perhaps pomalidomide, the mTOR inhibitor everolimus, and lastly, the BTK inhibitor ibrutinib. So once you've made the decision to treat, how do you choose among all of these options? So when you ask doctors, the three things that we're thinking about are factors related to the disease itself, meaning how slowly or rapidly the disease may be progressing, whether someone has underlying numbness and tingling or nerve damage related to the Waldenström's. And in some cases, we actually see the cranial nerves involved, the facial nerves, or nerves that control the eyes, the ears, swallowing, things like that involved, in which case we have to be, we know that this is an aggressive presentation. We need to treat it as such. We may need to add spinal chemotherapy into the spinal fluid to address that. We look at factors that are patient-related, related to you, to how well you are feeling, how fit you are, what your kidney function is like, what your liver function is like, what your blood counts are like, what other medical conditions you may have, and what other medications you may be on that maybe interact with the drugs that we may be thinking about using. And then in large part, we take into account, when possible, convenience, practical considerations, transportation. It's a very different thing if you live 5 minutes from your doctor's office versus 100 miles from your doctor's office. And then finally, we look at issues that are treatment related. So how long did you respond to the previous therapies you've received, and what ongoing side effects you may have. For example, if you had neuropathy, you may have had neuropathy related to the Waldenström's, but you may also have developed neuropathy related to your first-line therapy or previous therapies. So we'll take the treatment options in turn. The first group that we'll talk about are the monoclonal antibodies rituximab and ofatumumab. So rituximab, as you've heard throughout I think in a couple of the talks this morning, is an antibody, a monoclonal antibody directed against a protein called CD20. CD20 is found on normal lymphocytes and is found on the Waldenström cells and most Waldenström cells as well. So it goes through, when you get the infusion, it's going throughout your body looking for cells that have this protein CD20 on their surface and trying to kill those. You heard from Dr. Anderson that Dr. Gertz and colleagues had a study of rituximab as a single agent. The entire study involved 69 patients. Of those, 35 were previously treated. None had had prior rituximab. These patients received 4 weekly doses of therapy. The partial response rate, meaning the 50% reduction rate or better with these 4 doses of therapy in previously treated patients, was 20%. If you include the minor response rate, meaning the 25 to 50% reduction, that number certainly goes up, which isn't bad if you think about the fact that people had prior therapies and they only had essentially 1 month of therapy, and that was enough to get a 20% chance of having a 50% reduction. But the reason that rituximab is added and is the backbone to many of the therapies that we use is because not only did we get a partial, you can see that we're seeing a response, but when we went back and looked at patients who were treated in the rituximab era, since rituximab came out, versus people who were treated prior to the advent of rituximab, what you can see is that there's a huge difference in how long people have lived overall. So in the era prior to rituximab, the average median survival was about 5.6 years, whereas when we looked, we hadn't even reached the median overall survival at 13 years. We still hadn't reached the median overall survival of people who were treated in the rituximab era. So that is the part of the reason that rituximab is sort of the backbone on which other therapies are built, or regimens are built. So if you can't tolerate rituximab, are you out of luck? And the answer to that is certainly no. Rituximab is what's called a chimeric antibody, meaning it's part mouse, part human. So some people have trouble with the mouse part of that. The ofatumumab is, as you might imagine, so ofatumumab is a fully human monoclonal antibody, and so people who can't tolerate rituximab can sometimes tolerate ofatumumab. And so this was a study where ofatumumab was looked at in relapsed Waldenström's, and you can see that among these 28 patients who had had an average of 3 prior lines of therapy, the major response rate, meaning partial response rate or better, was 57%. So again, not bad for a single agent. But to that backbone, we can add other drugs, as I mentioned. So the first class we'll talk about are the conventional chemotherapy drugs, namely the alkylating agents and the nucleoside analogs. So you heard from Dr. Anderson about Dr. Dimopoulos' study, originally published back in 2007 and updated in 2011, looking at the combination of dexamethasone, rituximab, and cyclophosphamide. This was a study done in patients who were all previously untreated, and you can see the partial response rate or better was 74%, and the 2-year progression-free survival, meaning the length of disease control among people who responded, was 80%, so pretty good. And so although we don't have a similar study in the relapse setting, certainly this is extrapolated to the relapse setting, that if it worked frontline, we certainly expect it to work second line as well, second or third line as well. And then you've also heard from Dr. Anderson about the study done in Germany or in Europe of bendamustine rituximab compared with R-CHOP, which showed excellent response rates. You can see this was a study that included a number of different types of low-grade lymphomas. You can see the overall response rate, the major response rate was 93%. The complete response rate in that study was 40%. Again, this is across a number of different lymphomas. And the progression-free survival was excellent in the front line at 69.5 months, again, for all types of lymphomas that were included in the study. We don't have a specific study in relapsed Waldenström's, but Dr. Trion and colleagues have gone back and looked at the patients at Dana-Farber who have received bendamustine either alone or in combination with ofatumumab or rituximab, and you can again see that they have, the response rate is quite good. For all 4 of the patients who received single-agent bendamustine, both of the patients who received bendamustine, ofatumumab, and majority of the patients who received bendamustine and rituximab responded to those regimens. And these are people who had up to 9 prior lines of therapy, so that's quite a nice response rate to see. And the responses were maintained. The length of disease control was maintained. The average length of disease control was a little over a year. Moving on to the nucleoside analogs, these have been looked at either alone in combination with alkylating agents like cyclophosphamide and in combination with both cyclophosphamide and rituximab. These are 2 studies I'll show you. Both were done in the relapse setting. With 2 cycles of cladribine alone, the overall response rate was about 40%. And a second study looked at cladribine in combination with rituximab. For 4 cycles there, the overall response rate was 84.6%. And one of my colleagues, Donna Weber, who some of you may know, led a series of studies with cladribine in the frontline setting, and then actually went back later and looked at patients who were treated up front and then later relapsed to see how they did. So on the frontline 2-CDA cladribine alone study, 16 patients were treated. 12 of those later relapsed. You can see 10 of the 12 were retreated with a cladribine-based combination. 8 of the 10 responded. And likewise with the cladribine and cyclophosphamide combination, you can see of 38 patients who were initially treated, 19 relapsed, 13 were retreated, and 10 of those responded. So out of 18 out of 23 people who were retreated had a response at the time of retreatment. And the other nice thing is that not only did they respond, but the length of time they stayed in remission was almost as long. You can see it was the length of remission with the 2-CDA alone was, the median remission duration was 23.5 months, identical the second time these folks got the same treatment. With the 2-CDA Cytoxan, they stayed in remission for a little over 3 years, the second time around about 2.5 years. So it certainly provides a durable remission. Although I haven't showed you the data here, the numbers with the 2-CDA cyclophosphamide and rituximab combination are even better than these numbers here. Fludarabine is cladribine's cousin. It has also been studied. You can see these are the first 2 studies looked at fludarabine alone in the relapse setting. In both cases, the response rates, about a third of patients responded. The third study, led by Dr. Trion, combined fludarabine with rituximab, and you can see the overall response rate was quite a bit better at 81%. Again, speaking to the importance of rituximab in the combinations that we give. And again, these provided fludarabine alone, and certainly in combination with rituximab, provides a very durable remission. But unfortunately, both cladribine, fludarabine, and as well as the alkylating agents do come at some risk, and that's the risk of second cancers. So across Dr. Trion's study, as well as Dr. Racket looked at the MD Anderson patients, and Dr. Leloup in France looked at patients, again, treated with nucleoside analogs and compared those with patients who hadn't received nucleoside analogs. And in all cases, it does seem like there is a risk of second cancers with the nucleoside analogs and perhaps compounded by the alkylating agent. So something to bear in mind. The other risk or side effect that I think Dr. Anderson mentioned as well is that with the nucleoside analogs, it can be difficult to collect stem cells, or more difficult to collect stem cells, not impossible, but more difficult after nucleoside analogs are given. So if you are considering having your stem cells harvested, it's better to use something else until the stem cells have been harvested before using these drugs, if it's possible. So speaking of stem cells, let's talk next about stem cell transplant. So there are two different types of stem cell transplant. One is called an autologous stem cell transplant, in which the stem cells are collected from the patient themselves. The second is an allogeneic stem cell transplant, where the stem cells are collected from a donor. This is most commonly a sibling, but otherwise it can be a donor from a registry, a national registry. To collect the stem cells, a catheter is inserted into the vein that sits under the collarbone. A drug called Neupogen is given as an injection. That helps the stem cells to come out of the marrow into the bloodstream. Sorry about that. Once the stem cells get to a good level in the bloodstream, that catheter is hooked up to a machine. The machine will draw the blood out and essentially spin the blood once it's in the machine, and separate the blood into its various components. It'll pull out the stem cells, and the rest of the blood is returned back to the person from whom the stem cells are being collected. After the stem cells are collected and frozen, patients are given high doses of chemotherapy in an effort to kill as many of the Waldenstrom cells as possible. It's not perfect. There will still be some Waldenstrom cells left over. But in addition to killing the Waldenstrom cells, unfortunately, the chemotherapy is fairly toxic, and so it will kill off the normal blood cells as well, which is why a few days later, the stem cells are defrosted. They're given back almost like a blood transfusion. They're smart enough to make their way back to the bone marrow and to start producing new good blood cells. So part of the interest in looking at stem cell transplant in Waldenstrom's is because we use it quite commonly to treat multiple myeloma. It's used also quite commonly in other low-grade lymphomas. So since this Waldenstrom's is sort of a cousin of both, we presume what might be good for the cousins is also good for the Waldenstrom's. A lot of the data that we have is not prospective, where someone has planned to look at X number of patients with relapsed Waldenstrom's, for example, getting stem cell transplant and enrolling them at the time they're going for stem cell transplant. The data that we have is looking at retrospectively. So this data in particular looked at a number of patients who were enrolled on the European Bone Marrow Transplant Registry. All of the patients were transplanted between 1991 and 2005. This looked at more than 100 patients, of whom 75 had relapsed disease. You can say they had an average of 3 prior lines of therapy. The overall response rate, and the partial response rate or better, was 87%. Of these, 22% achieved a complete remission, and 5 years post-transplant, about 40% of these patients maintained disease control. What they found when they tried to tease out who benefited most and who had the longest disease control after transplant, they found that people who had had fewer than 3 prior lines of therapy for their Waldenstrom's, and people who had chemotherapy-sensitive disease, who were still responding to chemotherapy at the time they went to stem cell transplant, those are the people that maintained disease control the longest. Now, just like we were talking about having second cancers with some of the other conventional chemotherapy approaches with cyclophosphamide and nucleoside analog-based approaches, since the chemotherapy used for stem cell transplant is also traditional chemotherapy, often alkylating agent-based chemotherapy, there was about an 8.4% incidence of second cancers at the 5-year time point among all the patients that they looked at in this registry. So the other type of stem cell transplant, the donor stem cell transplant or allogeneic stem cell transplant, has also been looked at in the same registry of the European Bone Marrow Transplant Registry. In this case, all patients were transplanted between 1998 and 2005. They looked at a total of 86 patients who either received very aggressive chemotherapy, which we call myeloablative conditioning, or slightly less but still intensive chemotherapy called reduced intensity conditioning. You can see that the median age, the average age of people going into the allogeneic stem cell transplant was 49, and there's a reason that this is a younger population than you might otherwise see if you looked at all patients with Waldenstrom's, and it's because this is a very intense approach. It's not something we undertake lightly, and I'll show you why in just a second. You can see that the major response rate was quite good. It was 76%. And at 5 years, 60+% of these patients who underwent these allogeneic stem cell transplant were still alive. But what you'll notice in the next column is the incidence of graft versus host disease. So what that means is that the donor's immune system is reacting against the patient getting the transplant because they're seeing it as a foreign entity. And you can see with the myeloablative transplant, the very intense chemotherapy, the incidence of graft versus host disease was 61%. It was somewhat lower, but still significant with the reduced intensity conditioning. And when I say graft versus host disease, what the kinds of problems we're talking about are severe. It can be a very severe skin rash to the point that your skin is, you can actually peel off. It can be severe diarrhea, and the other side effects from there. Now, there are ways of managing this with immunosuppressive medications, things like steroids and other cyclosporin, other things that keep the reaction down. But it's a very tricky thing because you want the donor graft to react against the Waldenströms and keep the Waldenströms in check. But at the same time, you don't want the side effects, the graft versus host, where it's attacking your normal organs. And it's a very tricky balance to strike. The mortality rate, if you look at the last line of this slide, the mortality rate among people who didn't die or hadn't relapsed, their disease was still controlled. About a third of the patients who received the intensive chemotherapy died, and 23% of the patients who received the reduced intensity conditioning died. And so that's not death as a result of the Waldenströms, that's perhaps death as a result of side effects or perhaps unrelated causes. But still, it's something that we don't undertake lightly. Normally, we do not do this outside of a clinical trial. The next class of drugs, and we'll move to less intensive things, are the proteasome inhibitors. So the way I think of this, which is a very simplified approach, is the proteasome inhibitors kind of gum up the recycling machinery of the cell, the protein recycling machinery. So if you aren't able to recycle the proteins normally, then all those toxins kind of build up in the cell and the cell dies. So we have bortezomib is the most common one that we use, and probably many of you have had, otherwise known as Velcade. Carfilzomib is also emerging. It's in trials now for Waldenströms. And then the two below, ixazomib and oprozomib, these are oral versions of these proteasome inhibitors. And so there is actually a current study, I believe, going on with oprozomib at the Mayo Clinic and perhaps at other sites. And I think you can look for those in coming years. So this is the data with bortezomib in relapsed Waldenströms. The first three studies all used IV twice-weekly bortezomib. And you can see the response rates were between 27 and 60%. A later study looked at bortezomib in combination with rituximab. You can see the major response rate was 51% and included 5% complete responses. As Dr. Anderson mentioned, the problem with using IV bortezomib and twice-a-week bortezomib is the rate of neuropathy. So now that we've gone to once weekly, which is what was done in the last study, Dr. Gobriel's study, and extrapolating from the myeloma experience, we've gone to subcutaneous, under the skin administration, we can mitigate a lot of the neuropathy. We can reduce a lot of the risk of neuropathy that was previously problematic with bortezomib. So it doesn't eliminate it altogether, but it does certainly reduce that risk. Carfilzomib is the cousin of bortezomib. So one of the nice things and why we will be interested in the data coming out from the studies looking at carfilzomib is that it has a lower rate of neuropathy, at least in patients with multiple myeloma, and so I would expect similar things in the Waldenström's population. A few of the things to note about carfilzomib is that it can cause some fatigue, it can cause some nausea. That's unfortunately true with many of the agents we use. It can affect the blood count some. When we first started using it in multiple myeloma, we had some problems with the kidneys, but now as we've learned to use the drug better, that's less of a problem. In some instances, carfilzomib can also affect the heart, and that's also unfortunately true with bortezomib. But I think as we get to use the drug, know how to use the drug better, hopefully we can identify patients at risk for those sorts of problems and avoid using it in those folks. Moving on, we'll talk about the immunomodulators, thalidomide, lenalidomide, and then I'll show you a little bit about pomalidomide. So thalidomide alone has a response rate of about 25%. It's also been studied in combinations with steroids or the antibiotic clarithromycin or Biaxin, and has response rates between 25 and 83%. It's also been studied in combination with rituximab with a response rate of 64%. The problem with thalidomide, as you have heard, is that it can cause high rates of neuropathy. So it's not used commonly in Waldenstrom's. Lenalidomide or Revlimid has also been studied, and while this is very effective in myeloma, it's very effective in other low-grade lymphomas, and it does have some efficacy, as you can see in Waldenstrom's. This study was stopped early because it caused quite significant anemia, even with dose reductions. So we have also looked at pomalidomide, the third and the newest agent in that class. Interestingly, when we looked in myeloma, 4 milligrams is quite well tolerated, but in Waldenstrom's, even 2 milligrams was quite intolerable. So we went back and looked at 1 milligram and looked at about 6 patients there. And so this is actually the graph that you see at the bottom is the one patient who still remains on study. And you can see that his protein went up for a brief time, stayed stable for quite some time, and it took about 1.5 years for him to hit a partial remission. And since then, his protein has been coming steadily down. So now he's been on study for more than 2 years, and he comes and sees me every month, and we have mostly a social visit because he's doing so well, continues to work full time. So there may be a role for this drug. I think it's a matter of finding the right people and for us to learn how better to use this drug. The last 3 drugs I'll talk about are alemtuzumab, ibrutinib, and everolimus. So alemtuzumab is also a monoclonal antibody, but its target is a different protein, a protein called CD52 that is found on a lot of the Waldenstrom cells. It's a fairly effective drug in Waldenstrom's. About 36% of a very refractory population, a group of patients who were quite refractory to other therapies responded. And the disease control was maintained for almost 14, 15 months. The problem with alemtuzumab is that it suppresses other parts of the immune system that are important for fighting off viruses, and in particular a virus called CMV. So CMV reactivation was seen in about 18% of the patients, and 3 people actually died on the study, unfortunately. The other side effect that was seen was platelet destruction, immune system-related platelet destruction, and that also led to a fatality. So certainly not something that we use lightly, and certainly something that would need close monitoring for CMV if you were to receive it. Everolimus is another option, a targeted option. You'll hear more about this, I think, in Dr. Trion's talk tomorrow on targeted therapies. Its target is a protein called mTOR. And so this is an oral drug. Among 60 patients with relapsed Waldenstrom's, it led to a 50% response rate, which is quite good for one drug by itself. And people maintained their disease control for about 21 months. This did cause some significant problems as far as low blood counts. You can see about 2/3 of patients had significant toxicity from it, including lung inflammation in the lungs, mouth sores for some people, diarrhea, and fatigue. And the last drug I'll talk about is ibrutinib. And so I think a lot of you are familiar with this. Its target is a protein called BTK. Dr. Trion published the study, it just came out a few weeks ago, the New England Journal paper print form, although the data's been out for a bit. And so you can see that about 57% of patients had a partial response or better, and the time to response was 4 weeks, so a very quick time to response. Side effects include lowering the platelets, lowering of the neutrophils, pneumonia. Bleeding events you can see the rate is only 6% in this study, but it's something worth noting because it's been seen in other studies of ibrutinib as well. And since some people with Waldenstrom's have a tendency towards bleeding, just be aware of this. As far as bleeding after procedures, I think that's easily addressed by stopping the drug a few days before you would have a procedure. But there is some thought that ibrutinib has an effect on platelet function, so it's worth just bearing in mind. Not a reason not to take it, just something to be aware of. The other thing that is of note with ibrutinib is that it seems to matter whether you have a mutation in a protein called CXCR4 as far as your chance of responding. And I think one of the upcoming goals that we should have as researchers is to find a way around this, to overcome this mutation. But certainly, all the data, the excitement around this drug, we're thrilled to have the first drug approved to treat Waldenström's. So certainly look for this and its cousins yet to come. So what I've hoped that I have showed you is that we have a lot of options. There are a lot of options for relapsed Waldenström's, and these are some of the studies, and there may be more, but these are some of the studies that are currently available if you look on clinicaltrials.gov for relapsed Waldenström's. So this is an exciting time for us as researchers, and we hope that we can translate the research that's being done into improved quality of life and improved survival for all of you. Thank you.
And was an alkylating, one of those alkylating agents or something that prevented or kind of stymied the process of being able to harvest stem cells?
So that's the nucleoside analog, so cladribine and fludarabine.
Okay, because I had a terrible time harvesting stem cells and wasn't either of those. I was a bendamustine patient, so I was just curious. The other one is, you mentioned through some of these treatments as midway through your session that you may experience a secondary cancer. Have you got any statistics on what some of those cancers are worse, better, less destructive?
Which one should you choose to get? So it's a good question. So the concern is for myelodysplastic syndrome, or pre-leukemia and AML, certainly. In the MD Anderson study, what we saw was that there was a whole smattering of different cancers. There was not a predilection to one particular cancer, but others have found a sort of more of a concern for MDS and AML. But the piece that I'll add to that is that having Waldenström's itself, there was a paper by Dr. Castillo, who's also at Dana-Farber, that came out recently, which showed that having Waldenström's in general increases the risk of second cancers. So it may be that there are a couple things playing into this development of second cancers, the treatment, but also the underlying condition, the Waldenström's itself. So it's certainly worth keeping up with your general, not just with treating the Waldenström's, but also doing age and gender appropriate cancer screening. Go for your colonoscopies and your mammograms and pap smears and what have you. Thank you.